All right, well, good evening. Thank you very much for joining us again this evening. This is Cardiovascular Innovations Foundation, and we have yet another webinar for you that I think you're going to find very interesting, engaging with the esteemed panel that we have put together. First, let me thank you for joining us, and let me thank the panel and our presenters for being here tonight. We're going to be discussing atherectomy and calcium ablative therapies in the lower extremities. And we know that calcium can be a big challenge for us. So hopefully tonight it will be interactive with good discussion for all of us. Let me introduce the panel to you. I feel a little bit lonely tonight. My partner in crime, Dr. Subhash Banerjee, had an emergency and could not make it tonight. So I'll try to do my best, but I know it's not going to be the same. So I apologize that if you have to deal with me alone, but I'm lucky because I have four esteemed colleagues and friends that are here, and they're going to make sure that tonight is going to be very interactive and that hopefully we can learn from each other. Let me introduce you first with Dr. Lawrence Garcia, who is an interventional cardiologist from St. Elizabeth's Medical Center in Boston. Dr. Chris Metzger from Holston Valley Medical Center in Kingsport, Tennessee. Dr. Bala Ramanan from UT Southwestern Medical Center, Dallas, and our friend Dr. Nick Shamas, who is the President and Research Director at Midwest Cardiovascular Research Foundation, and he's going to be joining us as well. With that, just a couple housekeeping slides. Remember that this is a CME event. Tonight's objectives are listed for you. We're going to be discussing atherectomy, the optimal choices for various disease processes and patient presentations, and some of the complication and bailout strategies for lower extremity calcification. Obviously, you can get your CME credit, and I will show you the information as to how you can get it in the next couple of slides. Remember that all the disclosures have been identified, the conflicts of interest. There may be off-label discussion tonight, but these are, again, have been approved. You know, when somebody discusses off-label, we will definitely highlight those and discuss it as off-label. This has been supported by Abbott Vascular, Boston Scientific, and Medtronic, and I'm grateful for their commercial support of this CME event. And again, this is the website and the link, which we will share with all the attendees at the end of the webinar for you to be able to download and get your credit for this event. Next webinar is going to be on March 24th. So next week, Thursday night. We are going to kind of have a theme going on here. The next one is going to be on coronary calcification and the battle to deal with it, which is kind of the topic tonight for lower extremities. I also would like to again invite you all to attend the Cardiovascular Innovations 2022, which is going to be in Denver, Colorado on July 20th through 23rd. There's actually a fellows boot camp that's going to happen the day before on Wednesday. Mainly it's going to be coronary driven with some lectures around peripheral and structural, but I think it will be very interesting, and I think most fellows will enjoy it. It's going to be led by Dr. Manos Berlakis, our partner, who's going to be running that fellows bootcamp on the Wednesday before CVI, which starts on Thursday. And then there are a number of, obviously, webinars that we have discussed, like the one tonight. There is archives of these webinars on our website. Please visit www.cvinnovations with the S and the N.org, and you have basically available to you all the previous webinars that you can watch and also the discussions at will. Okay, with that, I'm going to hand the presentation to Dr. Lawrence Garcia, and he's going to be discussing with us tonight atherectomy cases for real world.
Hey, thank you, Mehdi, and I want to thank everybody for joining the meeting. Let's see here. You should see my slides. I also want to thank Mehdi. I mean, you guys have done a great job with CVI. I want to thank you for inviting me. And we were just chatting before we started that it'd be fantastic to actually see each other in person in the future. I have 10 minutes to tell you about everything in atherectomy in the real world, which is absolutely insane. So what I've done is I'm going to focus on 3 cases and use a specific device. It's going to be directional atherectomy, but I think we'll highlight the 3 potentials of how it works and what kind of patients we should look at. These are all my disclosures, including my equity interests and my current company. I'm going to start with the first patient, CC, 82-year-old male with history of hypertension, hyperlipidemia, coronary disease, status post-intervention, and peripheral vascular disease to include CAS, as well as Rutherford-Becker 3 claudication. His duplex revealed a long calcified SFA with preserved outflow. And what you can see here is relatively long, probably 15 to 20 centimeters of SFA disease with preserved popliteal. There is a normal trifurcation down to that level, and then some modest disease in the PT, but continues down to the foot reasonably cleanly. And so this is after directional atherectomy. And you can see where we started with the divots of that calcium have cleaned up very nicely. This is following the atherectomy for outflow, just looking for embolization, and the final angiography following a drug-coated balloon. So this really highlights the use of simple atherectomy for calcific disease, followed by adjunctive angioplasty, whether it's DCB or not, to allow you Rutherford resolution of claudication. I want to show a different case, which is a different patient, which is patient DC, 65-year-old female with history of hypertension, hyperlipidemia, chronic kidney disease, stage 3, and rest pain. Duplex again shows heavily calcified, long SFA lesion. And because she's at rest pain, you obviously would expect multivessel disease, which she does have. Her inflow and popliteal have significant lesions to them. You can see this moth-eaten appearance, which is the classic exophytic artery, and you can really see how the exophytic artery shows up here. And then she has reasonable flow in the outflow that is probably good for her despite her chronic kidney disease. So following atherectomy proximally, her outflow is to her pedal arch, but does not complete at the dorsalis. You can see that with, again, a directional atherectomy approach, we have a reasonably good result. The popliteal is plus minus, doesn't really clean up as well. And so following adjunctive angioplasty in the proximal segments with DCB, very pleasing angiographic result despite the long lesion. And in this popliteal segment, because of the suboptimal atherectomy result, here's a great use of combined therapy of atherectomy plus stenting. And the outflow is actually preserved and improved now to her foot. So this young lady I've taken care of for many years has done very well, and she continues to do well. But again, sometimes atherectomy to change arterial compliance is all well and good with the thought process of doing leave nothing behind or DCB. But in many cases with significant recoil, opportunities for stenting are critical. And I know that Bala is going to talk about some complications, but this third case is really a good example of how atherectomy works for you and sometimes against you. This is a young man with all the risk factors and a duplex with a very long calcified SFA lesion. Outflow is 2 vessels. We enrolled him into the reality trial a few years ago. And you'll see here that he has this really whoops, let's go back. I'm sorry. I hate this. Very exophytic artery here and here. You can just see how it's very moth-eaten throughout the course of it. Now, directional is great. Rotational is also very good. This was in reality, so this was a directional trial. And so I want you to pay attention to where this device gets proud, as we used to call it in the old days. It gets bound by the calcium and bows out, which means it's got a deeper cut. So you try to cut the mountain away from the calcium, but if you notice, I'm cutting towards the good side of the lumen, not the bad side of the lumen. And so this is a perfect example of what you can get into, which is a deep wall cut. This is adventitial, and we don't think much of it at the time of the adventitial staining, but when you end up with drug-coated balloons, this becomes very critical. And you can start to see some haziness in this filter. So remember, exophytic arteries tend to want to drop their calcium downstream. And this is exactly what happened here. And that's why distal protection is important. So this is now follow-up after DCB by about 6 months. And so we followed him for duplex, but clearly positive remodeling in this location is not a good thing. And this is following Viabon stenting. We posted that to get rid of this type 1 endoleak and actually have nice preserved flow downstream. So complications, as Dr. Ramanan will show, can happen with all devices, including atherectomy. Embolization and perforation likely occur. Know when to stop and treat differently when needed, I think, are going to be critical. So 3 cases for 3 different outcomes. I know Subhash told me that this is not really to show any data slides, but I can't really not talk about data. So in 2 minutes, there's a ton of devices. Just get used to all of them. This is the definitive data, again, useful for atherectomy in a sole adjunctive PTA alone only. Reality came back last year, really showed wonderful outcomes for high PAC scores in an 18 to 20 centimeter lesion, and total occlusions up to 22 centimeters with grade 4 PAC scoring. And their primary patency was remarkable at 83% in the combined therapy of directional plus DCB. And at the end of the window, very respectable 76. Remember and recall that how things fail become important. We've got so many devices now that we do not leave anything behind. And this was the Medtronic data that they allowed us to do years ago, really looking at DCB versus atherectomy. And orange, which is most focal, is very useful as opposed to green, which is occluded. Look at all devices go in and come out with either focal disease, and their failure rate could be just as bad when they come back occluded. So just be aware that your failure mode can be just as difficult to deal with than the index procedure. So in the real world, debulking remains a necessity, in my opinion, in many cases, and the data are compelling when used in combination with DCBs. Effectively treating plaque burden and arterial compliance is critical to many of our patients. DCPs have proven their benefit in both the short and long term, regardless of the Katsanos paper, in my opinion. And what we expect is that a durable outcome, whether a short tack or a long stent, with or without DCB, should be considered equivalent, though the failure mode of restenosis with or without atherectomy is best if focal, if not, and not diffuse. So thank you for your attention.
Dr. Garcia, thank you so much. As always, you make it look easy, but we're going to ask you some tough questions, and also the panel. I get to have the fun here. So the first question is that let's talk a little bit technical, because you did show some pictures and also you showed some data, but a lot of the folks that come to CVI, they want to learn techniques. So my first question is that, is there any lesion that you would never consider directional atherectomy for?
Yeah, so directional atherectomy, most of us will agree that directional is not useful for thrombus. Okay. If you have a aneurysmal segment to begin with, you probably don't want to start cutting further into that. So those are 2 probable big ones. For atheroembolic disease, it's awful. It would probably be the worst one to try to go after and capture a piece of emboli. So those are probably the most important ones. But having said that, some of the best uses are simple atherectomy for simple atherosclerotic disease. We've cut away dissection planes where people have created. You cut away the plane very nicely with directional. The technique on being able to directionally control that, though, becomes absolutely critical to know if you clock or counterclock, whether or not you're anterior or posterior. That really does take a lot of effort to learn. But once you do get facile with it, it's actually a wonderful device.
Yes. I was going to ask you maybe a couple more questions quickly. One is regarding the, in the old days, when we were learning this device and using it, people would say, do each quadrant, right? And then over time, we learned that, well, maybe that's not a good approach. Maybe we need to be more intentional. Tell us a little bit about directional. You mentioned it, but can you be more specific? Are there situations where you only cut in one direction, but maybe do it 2-3 times? Or how do you, just talk about that a little bit, how you use the device intentionally?
Yeah, no, I think it's a great question, Mehdi. For most SFAs, they're just run-of-the-mill, napkin rings. We will cut around the horn, so to speak. For the best in regards to directional control, and I know that Nick has shown cases similar to this, but in the common femoral, which I think is a wonderful use of this device, most plaque is almost always posterior. So this device is so well suited to be able to turn posterior and shave posteriorly. I think it's a real testimony to how well that device can perform in that location, and marry it to a DCB, I think, is a remarkable use of the device. So there, and these really eccentric lesions where you want to shave down the mountain, so to speak. Again, I can't imagine a different device. Rotational, no doubt, we'll get to it, but directional really does treat that one segment very nicely.
Nick, thanks, Lawrence. Nick, you obviously have experience with all of these devices. So, tell me, in regards to calcification, again, one of the things that maybe we were told many years ago that, if you have severe calcification is, orbital or rotational. If you have soft plaque, maybe directional. If you have, thrombus, maybe, pathway kind of a approach, those kind of things. Is there, what are your thoughts about calcium and directional atherectomy, since we're talking about directional for a moment? And, tell us about calcium, and do you use a different technique if it's heavy calcification? Sometimes the device may not go through. So give us some tips of using the technology.
So, Mehdi, great question. No question about it. The HOG device works well on calcium, and of course, like all atherectomy devices, you can't learn them all very well. So my advice is for people who wanted to be in atherectomy, you may want to pick up, a directional atherectomy, device, and maybe a rotational device, but try to master your device, because there's 9 approved devices right now in the US, and you're really not going to be able to master every single one of them. It's very, very tough. So bottom line, yes, it does work on calcium. It's important that you try to do more directional cutting. I tend to use a lot of Ibis, as you know, and Ibis helped me a lot, determine if I'm dealing with atherosclerotic calcium versus deep calcium versus, having both. For instance, if I'm dealing mostly with atherosclerotic calcium, the atherectomy would reach that very nicely. You can get nice debulking. But if you get deep calcium, it's a real problem. And many times, in our lab, we've been really adding, shockwave, to the directional atherectomy if we had to use it in these situations. So know your anatomy, know your lesion morphology, know your device, and essentially you'll do okay. A lot of these debulking devices eventually will accomplish the vessel prepping concept, which we're going to be discussing next.
You're on
mute.
Muted.
Yeah.
I was just muting so that there's no static. Dr. Rahman, and maybe one question for you related to, a lot of times people have argued that, okay, let's use atherectomy, or in this case, directional atherectomy, so we don't have to stent. Do you think there are situations where actually even if you, like Lawrence showed a case where he used Supera, but he said he did atherectomy because he knows it's important to get good vessel prep. Do you think there's a role for, in this case, directional, maybe other devices, even if you think that you may be putting a stent, to get the vessel prepped? I mean, how do you decide, when you should use atherectomy or versus, just do angioplasty and get the vessel prepped to put a stent, even if you intend to put a stent?
So I think if the luminal gain is not adequate, or if the runoff does not seem adequate, so like Lawrence showed in his case where the popliteal prep, it was marginal, and then the runoff did not seem adequate to help the patient with the symptoms or with wound healing. So if that is the case, and if it doesn't seem like the luminal gain is adequate even after balloon angioplasty, or if the runoff does not seem adequate even after atherectomy and supplementing with balloon angioplasty plus or minus lithotripsy, I think in those cases stenting is useful. And the vessel prep should help the stent at least expand, like we saw in the case that Lawrence showed.
One piece of data that you can probably fall back on, Mehdi, is the Jetstream registry. They had a lot of crossover there, but in that patient population, to Bala's point, those that did not have a good enough result, which was less than 30% or around there, they stented. And the outcomes on the stented group was similar, not any better and not many at all worse than the adjunctive just PTA arm. So if you get adequate debulking, simple PTA, as Definitive showed, actually is useful. Add to it a DCB, it probably is better. And so there is some data to support that kind of contention. Less benefit of the debulking, you don't get a luminal gain, you can go ahead and stent and you end up with a very good outcome.
Right, because, go ahead, Nick.
Yeah, I was going to say that that's absolutely an important point. And during when the JET registry was done, I'm not sure how much interwoven superior stent was used. I think quite low use in general. But right now, really honestly, when you have so much calcium around, especially in these popliteal, segments like, Lawrence have shown, this is a great stent to use in that place, and if you have to do it, that's probably my choice. I don't know if anybody else has a different perspective on this, but this has been my go-to stent in this situation.
Absolutely. I was mentioning it more from a standpoint of people think that when we say atherectomy, we are talking about never stenting. And, sometimes I feel like you actually need it, just like we do in the coronaries, to actually be able to expand the stent. And especially if you're going to use a specialty stents, let's call superior specialty stent or interwoven stent, you really need to prep the vessel. So either you have to do an excellent job with angioplasty and get it ready for that superior, or you're going to have to use atherectomy to get it ready for the superior. If you try to land the superior into a diseased vessel or a not prepped vessel, you're going to get into trouble. So, listen, I think we're going to get into it a little bit more, but I'm going to, for the sake of time, let me move on to Dr. Shamas. He's going to be discussing selecting an optimal atherectomy modality for a standalone or combination therapy. So very relevant to the Q&A that we just had.
All right. Thank you very much, Mehdi. Let me swap my slides. Here we go. All right. So thank you very much for the invitation. And I hope Subhash feels good here and join us with the next session. So let's go ahead and kind of pretty much emphasize some of the points that have been already mentioned, with Dr. Garcia. So these are my disclosure. So when we talk about, leaving the least metal behind, essentially you're looking at then optimal endovascular strategy, how you can accomplish that. And really the key, as we are seeing, is, changing vessel mechanics is really very important, to prevent recoil and negative remodeling, and of course, improve compliance for the reasons that have been already stated. But also it's important to protect, the distal vascular beds, and we've seen Dr. Garcia presented a case, where the filter already had a bunch of debris, and very well that preserving these vessels, infrapopliteal vessels, the tibials, is very important. Trying to keep the procedure safe and short as much as possible, but also important to keep smooth muscle cell, pretty much under control by using some anti-proliferative treatment. So again, the key for vessel mechanics is to get you the best lumen area gain, limiting dissections, limiting deep injury, and hopefully reducing bailout stenting, possibly improving drug elution. And when we talk about the procedural, protection of the distal vascular bed, essentially you could do it really both ways nowadays. You could use an embolic filter protection, but also you could use a system that has a built-in aspiration system, and this seems to work very well. And for vessel biology, we always talk about the anti-proliferative therapy, which is still a main treatment in our lab. But again, limiting adventitial injury is really critical, because as we damage that adventitia, we're more likely to see some form of, restenosis. When we look at appropriate vessel prepping, it really falls into two different camps. You could be either a person who likes to do soft debulking, where the lesion is reduced usually by about 30 to 40%. And that is really typical of the orbital atherectomy. This is what the compliance trial have shown. And this is also typical of the Orient laser. The lesion went down from 90 to 60. And that's what happens with the orbital atherectomy, the Orient laser, and the blade down mode of the jet stream. You get less embolization, less perforation, possibly less damage to the deeper layer of the vessel wall. You're going to get less MLA gain, but this is suitable, and I've been using this quite a bit in areas where there is mild to moderate calcium, fatty, fibrocalcific lesions or shorter lesions, and I don't have to be overly aggressive in that situation. And when you do aggressive debulking, and that's talking about the blade up mode of the jet stream or the Rotarex device or the Hawk device, where your lesion residual narrowing can be as far down as 30 to 40% residual narrowing, you're going to get more MLA, but also watch for perforation. And Dr. Garcia showed you a perfect case, of how you can end up with some aneurysmal changes, or actually really that's probably a perf that is contained. You probably get more embolization, but these sometimes are necessary to do, like in total occlusions and ISR lesions, where we have bulk of plaque that you need to really remove, and possibly in lesions with severe calcification. So again, the atherectomy devices, no matter what they are, the idea is to maximize luminal area gain, limiting dissections and deep injury, reducing bailout stenting. But just remember, we don't have very good randomized data to show a definitive positive impact on target lesion revascularization or patency in the femoral popliteal segments. So where do I use a lot of the atherectomy? A lot of young patients I use atherectomy on. I like to leave nothing behind in those patients who have many years to come. Task C and D lesions, complex diffuse disease, and of course you have to be intraluminal, and many times you have to verify that with intravascular ultrasound. And of course in areas of no stenting, like no stent zones, like the common femoral and the popliteal. I don't have a problem with stenting in locations where you have to stent, a bailout stent, then you don't have an option, but also some places like the proximal and mid SFA, where really motion and forces on the stent is minimal. Potentially stenting works just fine there. So again, we like to debulk, especially prior to drug-coated balloon. This is the finale data that keeps getting coded almost in every lecture. And the bottom line is, severe calcium and ARC of 270 or more clearly affect, the patency in many ways, reduce it very significantly, and that would affect your TLR rate and reduce your ankle-brachial index, as well as give you more lumen loss. Just remember, CTOs are not just collagen, they are loaded with all kind of plaque. You're looking at thrombus, you're looking at fatty tissue, fibrofatty, fibrocalcified. So these are lesions, that has multiple morphology, and picking up the right device in these lesions is important. So let me show you one case here of a fibrous plaque with limited calcium in a 62-year-old, claudicant, multiple risk factors, not a CLI patients, on the right medications, with statins and cilostazol, ACE inhibition, as well as aspirin. And you can see this lesion in the distal right SFA, looks subtotally occluded, very faint filling. I don't know if you see the calcium well, but it's kind of very calcified, not very calcified, actually moderately calcified, but you can see the runoff. There's only a single runoff there, and you can see the PT and the AT are both occluded. So of course, when you have a single runoff, you want to protect that runoff, no matter what you do. And of course, we have a filter there, to before any type of treatment. So again, here we chose, the jet stream device. I like rotational devices. I think they work nice for lesions, which are long and it just makes my procedure a little easier. And in fact, this is the second picture on the left here is following just the jet stream. And then I followed this with drug-coated balloon. As you could, angiographically, the lesions looks beautiful, nice, no dissections or anything like this, and it looks great. So again, I want to show you some Ibis images. I think it's really hard nowadays not to talk about Ibis images. And if you look at the top panel from the left to the right, this is the distal reference. And what you're seeing on the angiogram is what's inside that red circle, but the true vessel size is that yellow circle. And look at the difference. You're looking from 4 to 6 millimeter difference. So you have 2 millimeter difference, that you could have actually undersized your balloons with. So by using this Ibis, the right size, was chosen for the drug-coated balloon. Also, if you look at the middle panel on top, you can see that this is really a nicely fibrotic plaque, but look at where the arrow points, that yellow arrow points is to areas of translucency, areas which look like plaque rupture or thrombus, and so this is a mixed lesion, and this is a lesion that definitely will embolize, especially when you put stuff in it, very soft plaque, possibly thrombus, it's going to be probably end up downstream. And again, look at that same lesion. There's an arc of calcium there, which is a little less than 180 degree to probably it's a more of a moderate like calcification. So post the jet stream, and you can see that, in the lower panel, the reference kind of staying the same. But if you look at the post jet stream in the other two lesions, they look very nice, a beautiful kind of circular opening, right in this post-treatment. Now, the top panel still is your baseline, and the lower panel is where balloon angioplasty is done. And now you can see with balloon angioplasty a beautiful widening of the lumen, in that mid, picture down in the lower panel. And if you look at the lower panel, the right picture, you can see that there is now a dissection. And I outlined the dissection in yellow for you. And you can see this is a flap, that if you measure the lumen area, it's going to be pretty wide and nice, actually. This is really what a lot of our, MLAs are gained by dissections. But again, the question is how bad this dissection is. Are you going to do anything for this dissection? So in this case, this is, by the way, the chroma flow. You can see the flow going into this dissection. And it's kind of very clear that the flap, happening mostly it's an intimal flap. It's not reaching the media and it's not reaching the adventitia. So this is where the eye dissection grading system comes into place. We tend to grade those with the eye dissection grading system into A to C, which is intima, media, and adventitia. It will be A, B, and C. And also whether the arc of dissection is less than 180 degree or more than 180 degrees. So typically it's a 6 grading system, and A1, A2, B1, B2, and C1, C2. And again, the angiogram looks perfect, but then when you start looking by IVUS, you're going to see all kind of dissections. And in fact, it's 6-to-1 ratio, where you see 1 dissection on an angio, you will see 6 on an IVUS on average. So this is really important to remember, that IVUS is going to show you a lot more than what you see on the angiogram. The bottom line is the dissection you just saw, right there. Was mostly an A1 dissection. It's subintimal, it's not reaching the media or the adventitia, and it is less than 180 degrees. So this is the type of dissection we don't mess with. We leave it alone, and typically it heals very nicely. So let me show you a second case, as a CTO and ensuring intraluminal crossing in a 76-year-old limb ischemia patient. Multiple risk factor, had recent COVID, and you know exactly what I'm going to tell you next. And the medications include aspirin, and atorvastatin in this patient. And they can see there is on that right SFA double occlusion, initially a short occlusion followed by a long occlusion. You can see on the second panel from the left that it reconstitute all the way down into that, P2 segment, of the popliteal. And here we're trying to cross that. You can see a CXI crossing catheter, various type of wire, with a gradual increase in the tip, heaviness. And you can see this wire is not going in the right direction. Eventually, after a while, we were able to cross in, and got this wire through and put a NAV6 filter in, and you can see the jet stream device right there. I'm going to show you the IVUS in this. Look at the IVUS images. First of all, we have to make sure that this lesion is that we have crossed clearly in an interluminal panel because, we've had some difficult time getting that wire in. And in fact, Ibis helped us define that for sure. But also look at the lesion, how, hypoechogenic, very irregular, very soft looking. There's a lot of thrombus there. And following the jet stream, you can see beautiful opening, and following balloon angioplasty, this patient did very well. Mehdi, I don't know how much time I have, but I got another case or two. Can I present those, or do you want?
Maybe we hold them off. Maybe we hold them off. I wasn't sure if Dr. Metzger is going to make it, but it looks like he made it. So
He did.
we're going to maybe we hold them off if you don't mind. Maybe you stop sharing for a second, Nick.
All
I'm
right,
going to
let
ask
me
just
do that.
one question for the sake of time, because we had a
There you
good
go.
discussion right before.
Yes.
And then I'm going to move to Dr. Rahman, and then at the end, if you have time, we can obviously have more discussion and show more cases. But the one question I have is that you showed a very nice presentation and the challenge between getting the most debulking done, but not causing injury. So from one hand, you want to use devices to debulk, get the biggest lumen. From other hand, you want to make sure you don't injure the vessel wall, get into the adventitia, cause the kind of aneurysm that Lawrence showed. And what do you do when you're in subintimal space? Because the case you showed was luminal, at least the first one, with the jet stream. So do you ever do atherectomy when you're subintimal? And does that impact your choice of the device that you use versus directional versus, rotational?
Yeah, you know very well that every time we cross a CTO, there's a good chance you're subintimal somewhere, right? And it's almost about 40% of the time there is some subintimal path. In fact, this has been looked at, studied. And the key is, however, how deep you are into the subintima. If you're really superficial in the subintima, I don't have any problem starting with a rotational device, at a more of a less of an aggressive approach, or even the laser, in that situation. But the bottom line is, the patient will right away tell you if you're going deep. They are going to scream no matter how you have them under anesthesia there or under sedation. Once you go very deep, the patient will tell you. But the bottom line is, if it's not a deep subintimal positioning, I don't have any problem using, let's say, the blade down, mode of the jet stream or a laser device, and I watch the patient carefully, and of course, taking pictures, frequently to make sure you're not creating a perforation. But once you get through it, you actually disrupt that subintimal space and everything will be just fine.
Okay, that's great. Well, we're going to have more discussion around this, but for this, I just want to make sure that, we have plenty of time. So I'm going to move on. Thank you again, Nick. I really appreciate that presentation. We're going to move on to Dr. Rahman, and she's going to talk about potential complications and bailout measures.
Hi, good evening, everyone. Thank you for allowing me to present at this wonderful meeting. I have nothing to disclose, and I'm going to be presenting in a case-based manner, and hopefully we'll have a little bit of a discussion after every case and maybe at the end. So my first case is a 75-year-old male who had 8 weeks of right foot rest pain and discoloration. He has past medical history, included the usual risk factors of coronary artery disease and diabetes and hypertension. On exam, the toes of his right foot were cyanotic. He had palpable femoral pulses, but non-palpable pulses on the right side, though his left-sided DP pulse was palpable, and his ABI was 0 on the right. So he got a CT scan which showed a short segment occlusion of the mid-SFA, and this is a representative image with 2 vessel runoff via the AT, which was the dominant vessel, and the PT. There was also some atheroma in the thoracic and abdominal aorta. So we took him for a right leg angiogram, and this showed, as expected, the right SFA mid-segment occlusion and the runoff via the AT and the PT to the foot. So this SFA occlusion was crossed, and jet stream atherectomy was actually performed, and there was still thought to be some residual disease, and so this was actually stented. And the completion angiogram after the stenting, and there was post dilation of the stenting done, showed that the runoff appeared to be inadequate, and as you can see here, there was pretty bad embolization to the TP trunk as well as to the proximal PT and the perineal that you cannot even see. So obviously this is a serious and well-known complication of atherectomy. We spent quite a bit of time trying to suction out the thrombus using a penumbra, and also tried balloon angioplasty of the perineum as well as the PT. Ultimately, he did have a good runoff via the AT all the way to the foot, as can be seen, and he had good collateralization in the foot. And when we put a catheter down in the PT, really the whole PT was occluded all the way till the ankle, and there was some reconstitution via the DP. And so at this point, because the patient had a palpable DP pulse, and we spent a lot of time trying to reopen these vessels in futility, we decided to stop. And his symptoms actually resolved, and his post-op ABIs were actually normal on the right side, though as you can see in the digit waveforms, he had some microembolization, probably even to the digits. So for embolizations, obviously the best thing to do is to prevent it if possible. I think use of filter is really important. A filter was not used in this case, and I think that's one of the lessons that we should learn. Actually, Dr. Shamas has written about this, where he showed that with use of a filter, even particles more than 2 millimeters don't usually embolize distally and cause problems. So I think it's really important to prevent embolization if possible. Now, if embolization occurs, I think things we can do are obviously suction thrombectomy with either the penumbra device or an export catheter. And ultimately, there's always the option of an open cut down to try to, do an open thrombectomy. However, even open thrombectomy is very unlikely to succeed if the embolus is very distal to the small vessels of the foot. So case 2 is a 77-year-old male who had presented with lifestyle-limiting claudication. He's had a previous femoral endarterectomy 6 months prior, and on exam he had femoral pulses that were palpable distally and Dopplerable signals on the right side. He got a CT scan which showed a moderate to severe SFA stenosis, and then on an angiogram, again he had moderate to severe short segment SFA stenosis, and pretty good runoff distally. He actually underwent atherectomy of this segment with a very good resolution of the lesion. But, when on the completion angiogram, we noticed that there was a small branch of the PT that appeared to have active extravasation. So obviously this was a small perforation of a vessel. Most likely it occurred because of movement of the 014 wire during the treatment procedure. And, this is a relatively rare complication. However, it can occur and can have serious consequences. In this case, we treated this by placing a 3 millimeter balloon in the PT and doing a prolonged inflation for about 4 minutes. And when we did the angiogram after that, as you can see on the in the panel, there was resolution of the extravasation. When faced with this kind of a problem, other options include maybe coil embolization with microcoils if we are able to get into the branch and able to track the microcoils. But sometimes these branches are extremely small, and you may not be able to track a coil to this location. In this case, I've also used thrombin injection, where you can mix some thrombin with some contrast, so you can actually select like a bigger branch of the vessel and inject the thrombin directly into this area, so that you can cause clot formation or prolonged balloon inflation. And generally, if we have an issue like this, we admit the patient overnight and watch them closely for compartment syndrome, because that is a real possibility, especially if they've had some prolonged bleeding. So my next case is a 76-year-old who presented with a left hallux and second toe gangrene. Important history was end-stage renal disease, and he status post-kidney transplant in 2019. And he's had some coronary procedures and a previous right leg atherectomy and angioplasty. He now presented with the left foot problem, and he had obviously very low toe pressures on the left side. So we did a left leg angiogram And what was noticed that his SFA and popliteal were open. He had actually 2 vessel runoff to the foot. However, the PT was actually disease-free, just very diminutive. And the AT, as you can see, had multiple lesions, mainly in the distal AT and in the DP in the foot. So these lesions were actually crossed with a wire, and then atherectomy was performed. Once the atherectomy was performed and an angiogram was performed, as you can see on the right side panel, there was not really much filling beyond the mid-leg deep AT. And the question was whether this was mainly vessel spasm or was it an actual dissection. So we did we did some angiograms. We did a prolonged balloon inflation of this area. And you can see the proximal vessel looks okay. And initially, after treatment with the balloon angioplasty, the DP and the AT looked okay. However, once we redid an angiogram, again, there was very poor distal filling. So we actually used the tack stents, and we placed 4 tacks. However, that also did not result in a good outcome. And essentially, since the patient still had his preserved outflow through the PT, we stopped. However, this patient went on to get worsening of his foot ischemia and ultimately ended up with an amputation. So dissections are obviously a very serious complication of atherectomy or any interventions in the legs. And, dissections can be treated in different ways. Again, prolonged balloon inflation with the TAC endovascular systems where you do just focal tacks, or conventional stenting. If the dissection is in a more proximal area and none of these seem to work, then another option, if there's a distal target, is to do an open bypass. But obviously that's reserved for as a last procedure. So potential other complications that happen with peripheral interventions include rare events like vessel thrombosis or mechanical fracture of devices. As we discussed, dissections can occur from 2 to 24%. Perforations occur in about 4%, and embolizations occur in 3 to 15%. Thank you very much again for the invitation, and I look forward to the discussion.
Bala, thank you so much. Great presentation, and thank you for showing those cases, because I don't think we should take anything lightly. Usually, people show all the great cases. I always say to my fellows when they go to meetings, don't because they come back, they're like, oh, let's do this, let's stand on our head and do this for this approach. I just saw Dr. Metzger do it. I'm like, well. I'm like, let's be careful. So I think it's good to realize that that these things can have complications, and they could have very serious complications. So thank you for showing that. There is a question in the chat regarding what are some of the ways that you can differentiate. It's a great question. What are some of the ways you can differentiate a dissection, like this case you just showed, from, if you don't know if it's a spasm versus if it's dissection versus embolization, like a trash foot? Do you have any tricks in your bag that you try to figure out which one it is?
Yeah, that's a great question, actually. So obviously, there are a few things you can do. One, for vessel spasm, usually I try to inject nitroglycerin through a catheter to see if with injection of nitro, and provided the patient's hemodynamically okay, we inject that through the vessel, and then we wait and see if the vessel opens up on repeating an angiogram. So that's one thing we can do. The other option is to do Ibis, as has already been shown, to see what's going on, whether there is a dissection or not, especially after a procedure like atherectomy, since that does actually help define the anatomy pretty well. And also it'll help define exactly the area that needs to be treated if you want to treat it with something focal like a TAC vascular system. So those are some techniques that can be used to kind of differentiate these. And embolization, obviously, it's very hard. If a filter is used, then you can obviously see, and you can obviously see debris in the filter. That's one thing. But if it's a trash foot, I think an important thing is to compare it with the baseline angiogram that you get at the beginning of the procedure. And if it looks like there's absence of the small vessels in the foot, then that could indicate that there is a trash foot.
Wonderful. Well, thank you so much. If you could just unshare, I'm going to move to Dr. Metzger and have him do his presentation. First of all, thank you. I know you're working hard and I know you're on call, and but you're such a good sport that you still were able to make it here. And I want to thank your team for setting you up. And you're lucky, because if I had asked my people to do this for me, they would probably tell me, go. I don't know if I can say this on a Zoom call, but they probably would have told me go to hell. But so you're lucky. Anyway, Dr. Metzger is going to talk about intravascular lithotripsy and best practices, and looking forward to it.
Mehdi, thanks a million. Can you hear me okay and see my slides?
Yes, we can.
Great. All right. Well, first of all, guys and gals, thank you for your tolerance here. I was pressed into call, and it's been one of the worst ones. And so my team may have said some of the things you just said, but they still smile because we love each other. And Anna here has just been a tremendous godsend. So Mehdi, keep time. If we get to 10 minutes, just feel free to interrupt. We're friends, because there's a lot of cases here, but they should be pretty cool. In fact, I just finished shockwaving the left main and LAD insert of somebody. So this is good technology. All right. So let's do IVL for peripheral. Here's some of my thoughts here. Folks, this works unbelievably well in severe calcified lesions. It creates a predictably large lumen, larger than anything atherectomy can get you in its own, and yet has low dissection rates and very low distal embolization rates. And you can use it as standalone treatment, especially for access in aortic lag for TAVR, EVAR, and such. Here are some of my thoughts. Early, I would suggest that you do Ibis before and after, and you'll be amazed at what you see. Again, very helpful, giving you large lumens, and it is tremendous for calcified aortic iliac disease and for common femoris, others, SFA and popliteal, as well, as we'll show you. Some brief procedural tips. This is an 014 device. Sometimes if it's heavily calcified, you have to do some pre-dilatation to get it there, not usually, but sometimes. The beauty of an 014 system is you can put, in this system, it's not an atherectomy, you can put wires in as many vessels as you want and maintain access while you do your lithotripsy. You must size this thing correctly. The mistake people make is getting wimpy on it. You want at least 1-to-1 with this device. It's going to work. You'll be amazed. You inflate your balloon to 1 atmosphere, and then you activate the shock wave, and you can go up to 4 atmospheres. You can go up higher if you need to, but you want the shock wave to do the work, not the balloon. Okay. You have 300 cycles. Use them as needed. Okay. The energy is at the emitters, and the central emitter has the highest energy level, so you can center that as needed. You can do kissing shockwave in the aorta. We'll show you some cases of that. And remember, there are 8, 9, and 10 millimeter DCBs. They're for dialysis access, but it's a DCB of that size when you need it. There are some limitations. Some of this has changed because this is an older talk I did. But for above the knee, 60 cent, that's still the case. You only have one length. It's 60 millimeters. Period. Now the M5 Plus has 8 millimeters. That's phenomenal. It's great. There is now reimbursement. Again, this is an old slide, but remember that even when you have the reimbursement discussion, you don't need a distal protection device for this, like we've just heard in other talks. You can do it standalone. Remember, complications, distal embolization, dissection themselves are expensive in treating them. So, remember that. So let's look at some cases. This is you can see the calcium. I don't think I have to point with my pointer, and you can see the common femoral artery on the left. In the old days, I wouldn't have touched this. I touch them pretty routinely now. Here's up and around. Here is the calcium in the common femoral artery with a runoff. Here's the shock wave with a 7/60. Look at the result after that. Okay, very nice, no dissection. Add an 8 millimeter DCB with a long inflation. Look at the result and look at the lack of distal embolization without a filter. Okay. All right. Similar story on somebody's right femoral artery. Again, you see the heavy calcium. We IVUSed it first, 360-degree calcium, shock wave, several times into the SFA. Look at the result after the shock wave. IVUS showed no dissection, and then a long DCB inflation. Look at the results here. And I used to use a filter. Look how empty that filter is. I don't use them anymore. You don't need them. All right, this is a pretty difficult case. This was a guy who really needed to be done. He was not a surgical candidate, critical to ischemia. You could see the bifurcation. We had a shock wave of the iliac and then swallow that balloon. Look at the disease there. It's pretty nasty stuff. The nice thing, you could put wires in both of them. We SFA first and then profunda second. More shock wave in the common femoral artery. And very nice final result with no distal embolization in a very complex case. Standalone in the iliac. This is from my cell phone, sorry about that, but you can see it's pretty nasty stuff. And this is after shockwave and DCB. Again, stuff I wouldn't touch without shockwave. All right, let's go on to the aorta iliac. Here's heavily calcified disease in the aorta iliac and in the aorta. Again, shockwave on the left and a nice result after the shockwave. Same balloon, just take it out, put it on the right. Nice results just after the shockwave with no dissection. And simply finish it, in this case, with kissing VBXs. They expand nicely. Nice final result. Left common iliac, I want to show you how well this thing works in iliacs. You can see the heavy calcium. There's our shockwave. That's after shockwave. No dissection, nice flow. Makes it easy to finish the job. Obviously, we keep our VBX above the bifurcation of the internal iliac, covered stent, final angiogram. All right, moving on to the aorta. You can see just densely hypertrophied lumbars, severe calcium, difficult to even wire this. Gradient was greater than 80 millimeters. IVUS guided, you can see kind of almost a subtotal occlusion with recanalization and heavy collaterals. Here's shockwave on each side. Now this is kissing shockwave. We offset the emitters on both sides after IVUS. There's a nice result, much better aorta, no dissection. We pull the wire back, put a VBX in, finish with CRAB, and nice results, again, facilitated by the shockwave. This was a case we did live for TCT. I won't bore you with this, but heavy, you can see the ABI, severe calcium. You can see the severe 360-degree calcium, just a pinhole. You can see the duplex, which I, again, won't bore you with. But here we have the heavy calcium in the aorta. Shockwave from one side, shockwave from the other. Kissing shockwave. Look at the aorta there. No dissection, wide open. You could make a case maybe for not even, the gradient went away completely. And the question is, do you even have to? We did CRAB it. And final result for a live case. Ending up other territories, here's a popliteal that's heavily calcified, really focal. Again, the first shockwave, you can see that there's a waist here. So you move your emitters around, now it's fully expanded. This is after shockwave. There's nothing left. No dissection, no distal embolization. We just DCB'd it. Final result there. And again, boringly, no distal embolization. But I like boring when there's no distal embolization. Final, Nick had talked about subintimal. And you can see this dense calcium. We got across that, had to do a bunch of tricks to get across. Once we're subintimal, I really think shockwave is a little safer than atherectomy. This was one that brought out all the tricks. You can see it just looked terrible there. So we, after shockwave, did the pave and crack, put a VBX, and then a Sapera. You see how well it expands now. And final result facilitated by this device. So in conclusion, Mehdi and friends, I think this works unbelievably well in heavy calcium. It gives a very significant luminal gain with minimal dissection and minimal distal embolization. I think if you're a serious endovascular operator, it's an absolute must as a part of your armamentarium for treating these kind of lesions. And as we look for our new quarterback, thank you for your attention, fellow Steelers fans. And by the way, Mehdi, I will say this just in from Anna, the St. Peter's Peacocks have upset the University of Kentucky Wildcat.
Wow.
Peacocks. I don't even know who the Peacocks are, but that's pretty impressive. So,
well, happy St. Patrick's Day, by the way. We chose the wrong night to be doing this. We should be somewhere else right now.
I should not be on call. I should be drinking green beer. But anyhow, thanks, friend.
Well, thank you so much. Let me just, maybe I know we're a little bit tight on time, but maybe we can take 5-10 minutes. Can you unshare your slides for a second, Chris? Thank you.
Yeah, help me.
For the wonderful presentation. And
stop share, yeah.
There you go. Let me just, maybe we take 5-10 minutes if you guys don't mind. We always go over anyway, because, just good colleagues and good discussion. You mentioned the subintimal space for shockwave, and you said that sometimes you use it. There is some discussion out there regarding, the shockwave seems to work very well if you have circumferential calcification. You mentioned a few times Ibis, Ibis, Ibis. Do you believe that's true? And when do you, the cases you showed, I think not too many people would argue about using shockwave, but can you educate? I don't want people to think that, okay, every case I'm going to put shockwave. These cases, I think they make sense. Can you give us some guidance related to when you use it?
Yeah. So I don't want to be like everything, there's no perfect device that any of us would suggest that there's one. And your point is good. I've showed a bunch of shockwave cases there. This was actually from a shockwave symposium. So it's a little biased, but I will say this. I use it only if there's severe, usually circumferential calcium. Okay. That's when it is, in anything else, it doesn't work. It's just a balloon. But for heavy calcium that's circumferential, it works fantastic. Now, the only reason I said Ibis, Mehdi, is I think early on it's very helpful to you to see how well the result, what the results are. I don't think you need in every case, probably 75% of that I did not use Ibis for. And I wouldn't even love it in subintimal. In subintimal, I don't like using atherectomy, and I would only use shockwave in the one case there because it was so densely calcified and it needed help. So I would not use it routinely in subintimal. So I'm glad you brought that up. I would not want to suggest that that's the routine use. Where I would suggest it's used the most is if you are an experienced operator who has a good relationship with your vascular surgeons, or you are a vascular surgeon, okay? Then I think it works extremely well for common femoris that densely calcified that you think endo is better for some reason in your hands, or for aortic iliac. That again, you've done a careful risk-benefit ratio assessment and dense calcium in other places. I think it's only good for those cases, but then it is very good. Thank you. Lawrence, you unmuted. You were going to comment on this?
I was going to tell Chris, those are great cases. In your experience, have you seen, there was a question on the chat about embolization. And, what I have gleaned from dealing with the shockwave group and looking at their internal data is they deal with a lot of these exophytic coral reef arteries, and yet they in situ do not have, they in situ crack it, but do not have embolization. Are your experiences similar in that same respect?
Lawrence, great question. I'm telling you, and again, folks, I have a slight relationship with shockwave, but I'm talking from the heart and experience, not the wallet. Okay. I think for atherectomy devices, I always use distal protection. I'm a huge fan of a NAV6 with a exchange length bare wire. That's your best one. It's going to give you free wire, and I use it for everything else. And it's amazing how full the baskets often are. The mechanism of action here is so different that it does not create distal embolization, even in the coral reef of which you spoke. To the point that a huge proponent of distal protection. Now, Anna's right here with me. She's from Abbott. She doesn't like me saying this because she knows I love NAV6, but you don't need it for this unless there's something else you're doing outside of the shockwave that's going to embolize. And so the results are, I've done literally hundreds of cases and just don't see it. And we do final angiogram. This isn't like some of the folks, oh, I've never seen it. No, I mean, we look and you don't see it. And so it is truly different.
Chris, one more question related to aorta. You showed some nice aortoiliac, and we use shockwave, reasonably, frequently for our TAVRs and some of the aortoiliac cases here in Cleveland. But, what if you're subintimal? What if you're doing a CTO of the iliac and are calcified? What do you do in those situations? What is your experience if you are subintimal in the iliac? The ones you showed were mainly subtotal. I think most of them were luminal, but what are your thoughts?
So I do not like subintimal anything in the aorta or the iliacs. Okay. So my suggestion is everyone don't get subintimal. And if you do, stop. I just don't think anything good comes from subintimal stuff especially in the aorta. Never would enter the lateral wall of the aorta ever. Unless there was no other, and you were going to do endologic something. But no, I mean, what I showed you some intervals in an SFA is a little different animal, but I just do not think you should get subintimal and continue working in the aorta iliac as a general rule. For shockwave, anything else.
I appreciate that. Listen, I want to move a little bit for a couple of minutes to Dr. Rahman, and we didn't talk much about in-stent restenosis, which is unbelievable. 10 years ago, this whole meeting would have been about in-stent restenosis, or half of it, which is great, which means that we are not putting that many stents, which I love. But what do you do for in-stent restenosis? Do you have an atherectomy of choice? What are those? And do you always do it? Give us some insight.
Yeah, so generally I don't use atherectomy for in-stent stenosis. I know some people like to use laser, and I actually have a partner who uses directional atherectomy for in-stent stenosis. But I generally do drug-coated balloon or balloon angioplasty. And sometimes I'll use a scoring balloon to kind of break up the plaque initially, and then I will do a drug-coated balloon. I have actually tried shockwave also in in-stent stenosis sometimes, and that seems to work pretty well too. But I generally don't do atherectomy for in-stent stenosis.
So you raised a good point, because we use this sometimes in the coronaries. Any of you have used shockwave for underexpanded stents in the periphery? I have never done it in the periphery, but Chris, Nick, have you done that? Does it work in the periphery? In the coronary is not unreasonable.
Yes, it does work. Actually, we've used it several times, and I can tell you it's amazing because we've IVISed this thing before, and then after the shockwave, and dilated it, re-IVISed it again, and beautiful expansion of the stent that you have not seen before. So, yeah, it does work. I can tell you it does work from my own personal experience. I'd like to see a study on this, by the way. I haven't seen anything published about it.
Nick,
go ahead.
I was just going to say, I agree. Oh, go ahead, Lawrence, please. I'm sorry.
So the idea is that the shockwave wavelet has to go through the stent, so they don't know if it impacts that intimal space, which is what you're trying to disrupt. And so, but it seems to work. We've had one case of it, and it seemed to work nicely. But to Nick's point, I've just not seen any formal data on it. I'm sorry, Chris, go ahead.
No, I agree. My experience is a little different. You saw my enthusiasm for the shockwave on the initial. I think it's variable. The only time I would use it is if you can't expand it and it's heavy calcium and it's kind of your last ditch effort. We've seen it in the corner, as you mentioned, Mehdi. And sometimes it works and you go, wow, baby, ooh, and angels start singing. Other times, not so much. But it is, if it's an underexpanded stent in calcium and it doesn't work with anything else, you're only there's not a lot of other options, you know, other than bypassing it with something else. But I would say it's not 100%. You're going to get good results. You will see some amazing, some so.
How about Nick? How about you from a standpoint of in-stent restenosis? What do you have a device of choice for in-stent restenosis?
Yeah, I always debulk those, Maddie. I think it's important to remove some of that tissue, to allow actually, the best results possible you can get. I mean, I agree DCB works, covered stents work. We've already, laser by itself works, but, restenosis is so high. So typically I debulk, either with the Jetstream device or with the laser, and then I use drug-coated balloon right after that. I always embolic protection, with these. They are very high potential for distal embolization.
Let me ask Lawrence and move it to the bypass grafts. Lawrence, any experience you have with treating, distal anastomosis of bypass grafts or anything else within the bypass graft with atherectomy? Any thoughts on that? You think it's a bad idea, a good idea?
Yeah, no, we've had a ton of experience. Geez, we were one of the first adopters for directional. Gosh, it seems like a long time ago, and it was about 20 years ago. We had a lot of experience in vein grafts. The anastomosis is hyperplastic, and so this is very well suited for directional, rotational. You really can get away with a lot in those. We have done it in PTFE grafts, and I got to tell you, I got really lucky. PTFEs do not have the hyperplasia to the same degree, and the stitching, if you tear that, it's a zipper. And so the surgeons cringe, and they will never talk to you again. If they don't talk to you now, you won't lose much. But at the end of the day, this is one way to lose a graft in a very quick way. And so it is not recommended for PTFE grafts. And I would highly ask your surgeons to revise it. Do not do atherectomy there.
Okay, let me move it. I'm enjoying, there's a lot of information you guys are providing, so we're going to take advantage of it for 2 more minutes, if you don't mind. What about below the knee? I just want to focus for a minute because some of these devices are a little bit bulky. We talked a lot about directional. Shockwave also, at least in the coronary, sometimes it's challenging to deliver in my experience, but, any thoughts about below the knee? Let's start with Chris. Chris, for below the knee, have you changed at all? What are your options these days for below the knee?
And I may be a minority here on this. Maybe it's the grayness in here. I don't know. But I think below the knee, for the most part, I keep it relatively simple with balloons first. Often a focal force or balloon, long inflations with PRN drug-eluting stents. Now, there's exceptions. If it's heavily calcified, you may need to do something. And you're right, the shockwave is not the most possible balloon. So you may often have to pre-dilate it and then shockwave it and then add whatever. But I do not do a lot of atherectomy below the, unless it's densely calcified, in which case CSI, it was longer, but then the outflow embolization is a little bit of an issue. So I keep it simple, long balloons, scoring balloons, PRN, drug-eluting stents, and then occasional modifications as really needed, as mentioned.
Okay, I'm going to finish with the last question I'm going to ask all of you. And this doesn't happen that often, which is great. But there are sometimes these lesions where you can't pass a support catheter. You pass the wire, usually it's a CTO wire or some lucky wire that gets through. You can't pass the CXI or whatever support catheter you're using, whatever your choice of support catheter. You can't even exchange the wire because, you want to put a Viper wire or something, you cannot do it. What do you do? Let's imagine for a moment that you can't exchange the wire. I'm going to ask 2 questions. You can't exchange the wire. And what is your atherectomy of choice? Given that balloons are not going through and they are not doing anything to the lesion. I'm going to start with Bala. Bala, do you have in those lesions that the balloon is not working, you got the wire through, you have an option of exchanging the wire, because I'm going to go to no, you cannot exchange the wire. But first, I'm going to start easy on you guys. So you can exchange the wire. What is your choice? What do you do in that situation? Well, you're lucky because you can bypass, but we can't bypass. We can't do. We can't refer. But tell us, what do we do?
I mean, generally, I do jet stream as far as atherectomy. But you know, if you can exchange to a wiper and it's a heavily calcified lesion, then I would try CSI.
Lawrence, how about you, man? If in those situations, is there what is your choice? I know you're a big directional, but I don't think it's going to go in this one.
You know, what you asked Nick before, the definitive data showed phenomenal infrapopliteal data. And to date, I still don't do it. I have to echo Chris's statement. I just keep it simple down there. In the cases where you can't cross, you know, these crossing catheters for coronaries, these CTO catheters like the Corsair, the Turnpike, they are so tapered at the front end. I have not yet failed to get that across these uncrossable lesions in the periphery. And the coronary is a different story. But here sometimes, I just did a case this afternoon of a DP that was going to be slated for amputation. He just lost a toe and they were going to go up to his knee. And we were able to cross it with this Corsair ES and then dilate it up. And it worked out great. He has a viable foot again. But should you not be able to cross, laser in calcium is just not terribly good. Arion is distinctly different. It may be a choice. It may be too bulky to get down to these really distal lesions, but it is much better in calcium. And otherwise, I think that you're really stuck, in my opinion, if you can't get a device down there.
Chris, any?
So it depends on what the problem is. If it's heavy calcium, you change the wire, I'd probably use the smallest crown I could and spin it. If you couldn't exchange the wire, usually, as Lauren said, you can take a Mamba, whatever your favorite crossing little torquing device is, and get it across. There's actually an integrated 1.25 balloon and crossing. Do that, or take your lowest profile balloon and just do balloon angioplasty. It's usually going to get it. If that absolutely doesn't work and you can't exchange the wire, the only other thing would be a laser, because it can go over anybody's wire. And I'd turn it way the heck up and hope it goes across. But usually, if you take your time, you can get a small balloon or a crossing catheter across and do what's right. With the other exceptions, CSI, if you had to, or laser.
Yes. And Nick, any additional comments?
Yeah, you know, I tell you what, the 0.9 laser Arion, you know, like, Lawrence was saying, works really good. We just started enrolling patients in the Arion below the knee trial. You know, in fact, we enrolled the first 2 patients today, you know, in that study. And I can tell you it does work. You know, it does work. This is a very different type of laser. And the short pulse width is extremely powerful in terms of delivering a very high energy pulse there that allows you to cross, especially if you use the 0.9. I would use the 0.9 for something like this. I wouldn't go to a bigger laser if you can't cross, because it would be very hard to cross then. The other one will be, exactly, what Chris was saying. We try to get a 1.25 balloon, 1.5 balloon to try to create a small channel. If we can get that channel, then we can get the crossing catheter. We could switch technically to a Viper wire, and we can start doing some orbital stuff. I mean, I think it works really very nice using the 1.25, orbital atherectomy catheter. So either way, I think either the 0.9 laser or balloon dilatation with a 1.25 exchanging wire if you can, and then go to the CSI if you want to.
That's great. Listen, thank you very much. I learned so much myself, and I'm so grateful at this time of the night, after doing cases, after being in the OR, and after being in cath labs, for you guys to come and educate us and share your wisdom. I'm very grateful to that. Thank you so much. Also, thank you to all the folks that came to listen and to attend, on the St. Patrick's Day here in the Northeast. The weather was very nice. I don't know how it was in Boston, but we had probably our best day of the year today. It was beautiful. So probably people were outside. And so in general, thank you all, and looking forward to seeing everybody next Thursday at 9 p.m. We're going to discuss calcification in the coronaries and how to deal with those. So thank you. Have a wonderful week and weekend, and hope to see you guys next week. Thank you very much, guys.
Thanks, Mehdi, everybody.
Thank you.